Perfect. Thanks, Nat. Hello everyone. My name's Jack Williams. I'm the lead for palliative care and older adults here at Northwest Melbourne Primary Health Network. And I want to welcome you all to our webinar tonight. So, practical palliative care for GPs working together for better outcomes. So, really excited to have you all here and welcome you to the session. So to begin, I would like to acknowledge the traditional custodians of the land on which our work takes place. So I'm sitting on the lands of the Wurundjeri Woiwurrung people tonight. But at Northwest Melbourne Primary Health Network, our catchment also extends onto the lands of the Boonwurrung people and the Wathaurong people. I'd like to pay my respects to the elders past, present and emerging, and also pay my respects to any Aboriginal and Torres Strait Islander people in the session with us today. So just before we get into introducing our panel, we do have a bit of housekeeping. So it is quite important that we get your name listed on your Zoom account, just so we can acknowledge your attendance and link your CPD points to that. So how to change your name in a Zoom meeting. First of all, click on participants. So for those using the app, just click on your name. For those using a desktop, just hover over your name and click the three dots, and those on a Mac just hover over your name and click more. Then click rename, and then enter the name you registered with, and go from there. And I think Nat will be putting some instructions as well on that just in the chat. I will now introduce our wonderful panel that we've got presenting tonight. So first of all, we have Dr. Hao Ming Zhu. So Hao is a geriatrician and palliative medicine physician working across Melbourne through Northern Health and Melbourne City Mission Palliative Care. He has joined the Northern Advanced Care Planning team to continue to encourage discussion and understanding to promote person-centred care through shared decision-making. His work at Melbourne City Mission Palliative Care is aimed at improving access to specialist palliative care and residential aged care. He is involved in teaching and supervision and is interested in listening and learning from the stories we all have and share. We then have Dr. Terry Ahern. So Terry is a semi-retired GP at My Health Brunswick. He is passionate about care of the elderly, aged care, palliative care and chronic disease management. He is a member of Northwest Melbourne PHN's Older Adults Expert Advisory Group. And as well as seeing elderly and frail patients in practice, Terry regularly visits them at residential aged care homes and provides palliative care. Next slide, Nat. We then have Chen Che Lin, Dr. Chen Che Lin, I should say. So Chen is a palliative medicine specialist consultant at several hospitals and community palliative care services in Victoria, including Banksia Palliative Care Service. He also works as a general practitioner, committing to support people with progressive incurable disease to live as well as possible with the burden of disease and dying. He has continuously dedicated clinical and administrative commitments to improve care in the community. He is actively involved in teaching and supervision of medical students, medical specialist trainees, aiming to inspire a practice culture of academic excellence and human compassion across all clinical settings. And last but certainly not least, we have Dr. Catherine Oliver. So Catherine is a palliative medicine specialist working at Mercy Palliative Care, which includes Werribee Mercy Hospital and the Mercy Palliative Care Community Service. She is passionate about supporting people with advanced incurable disease to improve symptoms and maximise quality of life. She is also involved in preparing the next generation of doctors to care for palliative patients, from medical students up to advanced trainees in palliative medicine. So as you can see, we've got a wonderful wealth of experience and knowledge on our panel tonight. So just a little bit of a heads up with the structure of our webinar tonight. So first up, we're going to hear from Dr. Terry Ahern, and Terry's hoping to run his section a bit more as a discussion. So he invites any questions throughout his presentation. So please pop up your hand if you do have any questions for Terry, and we'll also have a brief question time at the end. For our other community palliative care representatives, we've got a little bit more content that we need to get through. So we'll have a question time right at the end of tonight's presentation. So you can hold questions till then. And also feel free to put questions in the chat in case you don't want to forget them. So without further ado, I'm going to hand over to Terry. Just got you on mute there, Terry. Still on mute there, Terry. There we go.
Have I? Yeah, right.
Yep, perfect. Well done.
Sorry about that. Yeah, welcome everybody. Thanks for joining tonight and putting in the time in to try and learn a bit more about palliative care. I'll try and give you a few ideas just from the basics, working as a GP in general practice for over 40 years and dealing with aged care patients in the community. And I attend one aged care home now, but I used to attend many. So I find palliative care is always rewarding work. You're really very much appreciated by your patient and by the family, and certainly a benefit to the community too. It's much easier than it used to be. It's particularly telehealth. It's really makes it more better communication. It saves you travelling out more often, and so it's valuable. I think particularly if you're using telehealth, you get better funding if the patient's registered with My Medicare. So the patient will always agree to that if they're happy to be bulk billed and for telehealth. And plus, at the moment, you've got the level E consultations for over 60 minutes, and that pays for your longer consultations and your home visits too. So we're always well supported by the community palliative care services. Just a simple referral to the one that's appropriate for your area, and they'll arrange everything from there. They'll just give you information how to go about it, and any medications that may be required. They'll recommend usually the 4 basic medications that are required: pain relief, antiemetics, sometimes something for agitation, and sometimes for restless or noisy breathing. But there's other medications too, and they'll help with the more complex problems. And they always have availability 24 hours a day, and the nursing service visit quite often and as required, and they have easy access to palliative care physicians, and we do as the GP too. Plus, we have the support of their mental health services, their counsellors, and their allied health services, which help with management of patients, particularly in the home. So in the otherwise in the aged care, it's even easier, and the aged care facility are very happy to have that support, and it always works out well as a team with the nurses and the community palliative care and yourself as a doctor. So just this basic. Next slide, please. We'll go on to the advanced care planning, and this is what sort of starts the ball rolling towards palliative care in the future for most people. But it's always worthwhile considering in most patients, particularly adults. And even if they're healthy, they may need to have a plan that's maybe urgent in the future. But more so if they've got a chronic illnesses, if they're got multiple illnesses, and or any patient that might have an early cognitive impairment, or anyone who suspected their health may be deteriorating. So the opportunities come particularly if you have a patient that you wouldn't be surprised if this patient might die in the next 6 to 12 months. You really need to jump in quickly and talk about advanced care planning and possibly palliative care. It certainly helps the family, and ask them things like if they've got more than one child or more than one carer, they'll you don't want to have any conflict of the family or the carers, and what the plan is for the future. It helps give guidance to them to put in plans for place for their palliative care and their end of life care. So anytime it's important that, particularly after hospital admission, where there might be a poor prognosis. So any new diagnosis might be a high risk there. I'll talk about the SPIC tool in a moment, and I think that's very helpful. But it's good to have a proactive approach. It's often handy to do this advanced care planning, or just bringing it up at the annual health assessment for people over 75, and you can train your practice nurse to start the ball rolling. The first thing is they must have information that they need, pamphlets or documents, or refer them to the Office of Public Advocate or information further about doing the health assessments, the advanced care planning. So it normally takes several consultations, and so you need to give them pamphlets to go home with, and then come back and have further discussions, often with their family, or at a prolonged consultation later on. Next slide. We're just talking about the SPIC tool, which a bit funny how it's SPIC tool, because it's SPCIT, but the Scottish have gone a bit strange and put it SPICT. So it's the SPIC tool, which is used to help identify people whose health is deteriorating and assess them for unmet supportive and palliative care needs, and it's to plan care. So there's a list there of the ones they recommend, looking for general indicators of poor or deteriorating health. So when a patient is getting lots of unplanned hospital admissions, is the first one. Secondly, where the patient's performance is slowly deteriorating, getting very poor, with limited reversibility, and the person, for example, might be staying in bed or in a chair for more than half a day, so that you know they're deteriorating. Maybe a person who depends on others for care due to increasing physical or mental health problems. The person's carer needs more help and support. The next one is progressive weight loss. So they're losing weight, they're not able to gain their weight, they remain underweight, and they might have low muscle mass. The next one is probably the most important one, is persistent symptoms despite optimal treatment of underlying conditions. And lastly, the person or family asked for palliative care, chooses to reduce, stop, or not to have treatment, or wishes to focus on quality of life. So I think there's 6 very easy to remember to discuss later on, and it's probably just unplanned hospital admissions, their performance is just deteriorating, they're getting persistent symptoms despite optimal treatment, they're very low weight, and otherwise the family aren't managing, or they ask for help. So keep that in mind for further discussion with the family. Any questions, please interrupt. Next one is the illness trajectory. It's to be considered in patients with poor prognosis. And it's important to be able to recognise a patient's stage of deterioration as either at a risk of dying within the next 12 months, or likely to die within the next few weeks or months, or dying within days, or wanting to go home. Different stages. So consider discussing palliative care options with these patients. And the GP plays an important role in managing those symptoms in conjunction with the palliative care services. So if you look at the next graph, you can see on this one, the indication on the left is the function, and on the bottom line, it's time. The first trajectory, in the lighter area, it's active treatment, and in the shaded area, palliative care. And the top trajectory for cancer trajectory, it's a short decline. So they have active treatment for some time, and then there's a rapid deterioration into end of life, and then terminal care and bereavement. The second trajectory is organ failure trajectory, and that's intermediate with acute episodes. So they may just deteriorate. Just to point out the other part where you got palliative care is you may still be having palliative care plus a minor active treatment for advanced disease. So you're still having some treatment for these people, but they're deteriorating, and they suddenly deteriorate quickly with an acute episode for organ failure trajectory. And lastly, it's the trajectory 3 is for dementia and frailty, and it's gradually dwindling. It starts at a low function level, and you reach palliative care at an early stage. You still may be trying some active treatment, but it's worthwhile having the palliative care for a period of time to help support you in that stage. Okay, for billing, it's worthwhile getting the billing correct and getting rewarded for your hard work. It's not always easy, and it might as well be rewarding financially, as well as your thoughts of doing well for the patient and the community. So always ask your patient to register, or the family to register with My Medicare to enable the longer teleconsulting, video consulting, and care planning and reviews. Teleconsults with the patient, obviously, welcome to attract a Medicare rebate. But if the patient is with a nurse or their carer, then you can charge a fee. But if the carer or nurse rings you without the patient present, then you can't charge a telehealth consultation. So it's best to get them to call if you like to call them when they're with the patient there, so to get a bulk billing for a rebate. We have the level E consultations now, which is funded a lot extra for 60-minute plus consultations in the home or in the consulting room. Case conferencing, I think, is very valuable. I use it a lot, and I always try to organise that so it can be. It's good to work out the problems in the past, and work out what solutions you have at the moment, and what the planning is for the future. And it works out as a team. It gives you a comprehensive, coordinated approach. And usually it takes 20 to 40 minutes or maybe more, and it's well worthwhile. So you need 2 service providers. That's the only concern, and you might use the palliative care team. There might be 2 people there that talk to you on the phone or in person, or you might have the palliative care nurse and an aged care nurse, or you might have sometimes it might be a pharmacist and a palliative care team, or an aged care person. So there's different ways. As long as you've got 2 other service providers, the family or the patient obviously don't count. Home medication reviews are usually always appropriate, and can be quite supportive, particularly if the patient's still on other medication. But even to help you with your medication issues, it's worthwhile. It's every 12 months, and home medication review, item 900 in the for the home patient, and 903 for residential medication reviews. Next slide. Just a bit more detail. It's just to give some examples of suggested time frame and different item numbers, and you can refer to MBS online to get some idea about the details, and has the item number there. So main one is anyone over 75 can have a health assessment every 12 months, and that includes the nurse time is included in the time, and normally the nurse is spending up to 45, 50 minutes, and then the doctor, anything up 20 or more, will have an item number over 60 minutes, which is pays quite well. It is possible to do a GP management plan in the team care arrangement at the same time, or otherwise you may get a patient back and do that at another time. It's always they're always eligible because of their chronic disease or a terminal disease, and they've always got at least 2 or 3 service providers. Mental health treatment plan may be recommended. Most patients are suffering mental health problems, including depression, to be in the later stage or palliative care stage, and need all the support they can have, and may need referral to psychologists if need be, unless they may be getting it through the palliative care service. Post competency, I've mentioned before, it's usually very rewarding, and you need at least 2 other service providers, and the palliative care nurse or physician, or one of the palliative care allied health people, along with someone else, like a pharmacist or the aged care home nurse, can be make it worthwhile. Medication review, mentioned if they've got more than 5 medications, or just complex medications, which they would have if being in palliative care. Level D consultations. Well, that's for longer consultations to discuss advanced care plans. Otherwise, you may need a level E, but it usually requires several consultations, and certainly giving out the information to come back and discuss it later. Later on, you may have a mental health plan review, a GP management plan review, a team care arrangement review. Other case conferences, you have up to 5 per year in the calendar year, or sorry, every 12 months. And otherwise, a practice nurse can do 10997 for their assistance in the management plan or chronic disease management, or otherwise they can do it over the phone or with the other item number. And we can repeat the health assessment after 12 months. That's just an example of a way to bill. Next slide, please. Lastly, the palliative care conversations. So it's emotional support that's ongoing with the family and the obviously the patients and the carers, and often that might be on the phone or in the presence of the patients, and normal usual counselling skills, listening to the problems, and answering any of their concerns, answering any questions they have. And obviously the community palliative care service is a great assistance in this process, with the nurses and counsellors and social workers and others. So it's a wonderful service to have. So I highly recommend it, and I think I'm finishing from there.
Thanks, Terry. Just quickly, I will throw it open to our attendees if there are any questions for Terry. No, it doesn't look like there are any hands there. Terry, just a quick one from myself. Just with advanced care planning, do you use any techniques or tricks to help, I guess, the patients return their advanced care plans? I know that it can sometimes be a bit of a challenge um, getting sort of a completed advanced care plan back.
Yeah, I think it can be difficult, but just bringing the topic up and letting them know about the information and giving them the information. You need to have the documentation to let them take home and discuss it with their partners or their family, and to try and arrange a review booking to come back and discuss it further with yourself or the practice nurse, and make sure you give them the benefits of the advanced care planning. It's a guidance for the family to make it easier for their management in their in palliative care or end of life care. So just detailed explanation and giving them information, I think, is the main idea.
Yeah, terrific. Thanks, Terry. We might just get the next slide up there. Nat, yeah, perfect. So we won't go through this slide, everyone. This is just a bit of a summary of all the service details from Melbourne City Mission, Banksia and Mercy. So quite a useful resource, sort of showing the different services that our community palliative care services cover in our region. We'll be sharing this with you all at the end of the meeting today. But I might now hand over to Chen for his part.
Thank you very much, Jack, for coordinating this wonderful opportunity for us to talk to our GP colleagues, and the support from the Northwest Melbourne Primary Health Network. And thank you, Terry, for a great start of the session and good insights into what it's like in doing the preparation work in the front line. And my name is Chen. I'm here to talk about Banksia Palliative Care Service, which is a community palliative care service in this catchment. And but we have here, of course, Hao and Catherine from Melbourne City Mission and Mercy Palliative Care as well. And again, we all function similarly with subtle differences, subject to local resources and availabilities. But the key is we're all here to support you and share care with you to look after patients with palliative care needs in the community. So, yeah. So a quick overview of my section is going to talk about what is palliative care, how it is delivered, who benefits from it, and how to identify patients in terms of timely recognition. And we've touched on SPICT already and earlier. And where does community palliative care sits within GP, residential aged care homes, residential in-reach and inpatient aspects of care? What supports can we provide? Interventions, medications, and practical supports to enable end-of-life care at home, bereavement support, and perhaps most importantly, I want to talk briefly about verification and certification of death in the community, and of course, when to refer and referral process. So what is palliative care? And many of you would have come across this already, and this is probably talking to the converted, because if you're here, you probably already know what we do and or what we all do in a sense. And of course, what palliative care is a person and family-centered care provided for a person with an active, progressive, advanced disease who has little or no prospect for cure and expected to die, and for whom the primary treatment goes to optimize the quality of life. So the key points are they're living with life-limiting illness, that there's an expectation in a sense, or a risk, in fact, sometimes it is, that because we don't always know whether for sure how long people have. and certainly people may have palliative care needs when they are actually still have curative options available, but making sure they have a plan B. The focus is on quality of life. The key is it does not equal to no care. So patients can receive palliative care together with other therapies that are intended to prolong life. So in fact, people who we can't fix actually need more care. So it's very important to remember. And it's here to, in addition to the treatments, if available, and to make sure they're looked after if not. So the aim is to help patients live as actively as possible. We do regard dying as a normal process and provides relief from pain and other symptoms, intends to neither hasten nor postpone death, and integrates psychological and spiritual aspects of care, and using a team approach to address the needs of the patients and their families, and offer a support system to help the family cope during patient's illness and in the bereavement. And that is because living with dying is essentially living with a progressive, fluctuating, perhaps, debility, and people rarely can live well by themselves, and they do need their family members around them. So it is a relationship and family-centered approach on top of the person as well. So really, everyone with a life-limiting illness condition can benefit from palliative care. And that may be the poster boy cancer, or very, in a sense, not common, fortunately, but diseases with very high care and symptom burden, like progressive neurological diseases, including motor neuron disease, can be an end organ failure, and most commonly heart, lung, and kidney, in fact, commonly altogether. Dementia, of course, is another very high, and now I believe that the commonest cause of death in Australia, and lastly, it includes pediatric patients as well. It includes everyone, and things like inherited metabolic disorders. It comes to mind when we look at pediatric population. And we talked about SPICT already, and but really it's when there's multiple unplanned crises, especially those which are life-threatening, and that there's a review or discussion of goals of care to align with a more palliative approach, we say, and that's when people would benefit from palliative care. And it's important to have a timely recognition, and often you will see early palliative care, and that's defined as palliative care delivered when they are still benefiting from treatment or life-prolonging therapies. But really, practically, it's timely rather than early, because when people need the care, it's better that they already have the links known to the program and is aware of the approach. And otherwise, there'll be a massive adjustment cliff when they suddenly need a lot of care and knows no one in the area and knows how things are, how they can get looked after. So I was just gonna quickly mention there's some specific transition points, especially things like cancer when people cease chemotherapy. Oh, sorry. But yeah, essentially, if in doubt, call and discuss, and we can talk about whether it's time or whether it's a meet and greet, but maybe a window of time without regular contacts, and yeah, going forward. So, sorry, next slide now. Yeah. So palliative care is provided by really everyone. And there's a lot of different types of definitions out there in terms of specialist palliative care and generalist palliative care. Really, from my perspective, the most useful way to think through this is that everyone needs to be able to and needs to participate in providing palliative care when their patients are dying, whereas the specialist services are those services who only does palliative care and 24/7. So, and the key to remember is specialist palliative care is not here to take over. We're here to support everyone else in delivering the best care possible. And it's barring select few situations where people do need to come into a inpatient palliative care unit, and for duration when they are on the unit, then yes, they do have all their care needs and some management needs provided by a specialist service, but which is only the very small proportion of their journey, and most of their journey they will be spending time and needing support from everyone together, and that could be just the generalists themselves, or could be a combination of generalist and specialist care. So it needs to be able to be provided at home, at the unit, the specialist healthcare unit, as we discussed before, in hospital, on other wards as well, in residential aged care homes, essentially anywhere a person identifies as being their home, in addition to their healthcare facilities. So we do want to focus on the community in this talk. And the reason is most people, when we say most people wants to die at home, this is based on previous surveys, and that's both internationally and nationally, and also locally. And the South Australia study is referenced because it's one of the more recent ones. But ultimately, everyone, about 70% of people says they want to be at home when they're dying. The reality is most people don't. And that's half the people in Australia die in hospitals, just over half, and the rest in aged care homes or at home. Yeah, sorry. Yeah. Which is why it's very important to, and thank you for your interest in community palliative care, and hopefully by attending today, together with us, you can help us improve this number and also overall quality of life and care for our shared patients. So I want to go through what supports community palliative care can provide. And we talked about earlier that there may be some variation in service in different providers. It's mostly similar in suburban Melbourne. And it's certainly there are bigger variations when it comes to regional Victoria. However, again, the key is finding out at points of care who's available, who's there to support. We are a specialist team of health professionals, so including palliative care nurses, probably the biggest component of a suburban Melbourne community palliative care team. And social workers make up the next biggest component. And we have allied health assistants and physiotherapists. Other services often have occupational therapists and art and massage therapists, and other services have music therapists and also volunteers. And lastly, we do have palliative care physicians, specialists available to support the GPs, but it's important to know that we're not here to take over the GP's role. and to make sure the GPs are the main medical care providers, and with our support to for patients living and dying in the community in Victoria. So one of the big key is support 24/7, and that's generally phone support at least. And for Banksia, we do have overnight call out available as well. So that's on top of regular assessments, and to make sure there's a care plan implemented for all the person's symptom needs and care needs, but also to help troubleshooting, because we don't know when another complication may occur, or when the person may deteriorate and their care needs escalates. And therefore, having a 24/7 availability to help troubleshoot and coordinate care, and in some instances to attend in the home, is very important. Pain and other symptom relief is generally the priority, because pain and other symptoms like nausea and agitation often are the biggest barriers for the person to participate in any activities of daily living, or just have a relaxed time. Equipment and social work input to help the family and the patient to manage care at home, and health input with some of the non-pharmacological benefits to help improve their quality of life, and also respite and support where if the care is too tired, have the direct links or support to help coordinate respite to relieve the carers and allow them to be just family members for periods of time in this very intensive situation. We're able to arrange direct admission to inpatient palliative care, and this is an important aspect because it reduces stress to the patients and the carers, and also assist in reducing the burden to the healthcare system by avoiding the need to present to emergency. Saying that this is needs very clear goals of care, and because people who are still receiving treatment, we will need to talk about whether they do need further investigations that will be accessed easier via the emergency department, and so it is important to have a clear discussion about a safe but also useful admission to palliative care units, because last thing we want is someone come to PCU and suddenly deteriorates but still needs to have additional treatments, and a lot of PCUs actually are not located with the facilities to do investigations, and they may need to be transferred back to ED as well. So it is a nuanced process, but it's an important pathway that we have. So again, community palliative care and residential in reach, there's a lot of similarities in that, but the first and foremost is that both are in addition and not instead of general practitioners. So, but if in doubt, just call. So we all work together closely as well. So and the InReach teams can certainly provide emergency support and talk to the community palliative care teams and hand over to each other as required. So the key is, if the patient is in strife, escalate. At Banksia, we do have a bit of a collaboration with the Northern Health InReach, and you're working on one with the Austin InReach as well. And this is just an example of how we explain to the residential aged care home staff about who to call at the time of crisis, and if people have unclear goals of care, needing assessment for acute decline of symptoms, and there's no palliative care medication charted, and they do need regular medication management and rationalization, then we advise the facility to go in reach. And if they have clear goals of care to remain in the facility and have complex symptom management needs, and have the medications have been rationalized and also charted for palliative care purposes. And then if they need bereavement and psychological support, we advise them to call the community palliative care. But it comes back to, if they call one or another, we will help them coordinate and redirect care as needed. And we certainly work together as well. So it's not uncommon that, in fact, both are involved at different periods of time for the same patient, and depending on the need at the time. So just some quick examples of the numbers, and just to give everyone a bit of an idea of where our referrals come from. And as you can see, because we do take self-referrals, but mostly it's still from the healthcare staff. So 38% comes from GPs and other health specialists in the community, and 38% comes from inpatient and other inpatient palliative care services and inpatient acute services. So 16% comes directly from the aged care homes, and only 8% comes from the relative and friends. And that's it's important to know, if the person self-refers, we still need to chase up all the medical notes. So if your patients would like to access palliative care, please, we still very much prefer talking to yourself and have some additional updates, whatever you have, so we can work together as well as possible, as quickly as possible. In terms of the numbers, you can see nowadays it's half and half, non-malignant and malignant. And in a sense, we also have patients, if you're long enough, you're bound to have a cancer somewhere as well. So it's quite a heterogeneous cohort nowadays. But what's the same is, if there's a risk of dying and that they have symptom and care needs, it's important to make sure that we get involved and support their care together with yourself. You can see in terms of deaths, so hospital inpatients, 40%, so and home, which we include residential aged care homes, is 60%. So better than the national average, but not by much. And there are inherent challenges in setting up care at home. On the other hand, we all do our best, and certainly even in suburban Melbourne, where a lot of resources are available, people still need to have rapid care coordination and supply of equipment and things to make sure we set up that environment at home. So, and I've put slightly cheekily that the GP engagement, including provisional certification of cause of death, on the top, because of course this session is about engaging our GP colleagues, and indeed we still need the equipment. We need the medications to manage symptoms, and they do need regular nursing visits on top of troubleshooting support, as we talked about before, and the family needs care as well. And but yeah, and just highlighting the GPs are indispensable in setting up end-of-life care at home. So we talked about regular visits, and comes from what we say we're specialist palliative care nurses, and these are nurses who only does palliative care, who are very experienced and are able to provide a bit of guidance for a symptom assessment and a trajectory of patients, and also guide the family in terms of where things are at, what to do, and recognizing times where things need to be escalated. Equipment, fairly straightforward. If the person can't get out of bed, then if we're able to get motorized beds or hospital beds at home, then it will help not only prevent care complications in the person, but also help the carers to reduce any strain on their backs, and able to provide the care the easiest way possible. Banksia does fund equipment for 6 weeks, and there are various local setups for additional equipment funding. And there's support from social work and grief counselors to provide emotional and social support to the patient, but perhaps equally important, if not more important, is their carers, and because they're doing most of the care. And I think about 90% or more of the care really is provided by non-professional carers in the community. So very important to be able to support them. And allied health input such as music therapy or massage therapy, often very useful when there is emotional turmoil or adjustment distress, and going through that, the non-pharmacological strategies and interventions often goes a very long way. So medications, something that's arguably unique in palliative care, although we do have, as you would be familiar, midwifery as well, we're in advanced practice nursing, but in palliative care, the specialist nurses will provide advice and around symptom management medications, and that's because they're experienced in what's generally effective and good at being your eyes and ears and picking up what the problem has been. But these are suggestions, and certainly not taking over the responsibility or decision making of the general practitioners. The general practitioners are the main treating doctor. So it's, if you would, nursing assisted assessments and prescribing, and another, I should say, unique aspect is the anticipatory prescribing, and that is around supplying of injectable medications, and also in the form of clonazepam, which is a buccal/sublingual drop of clonazepam, and just a small quantity to be in the house, because if someone is deteriorating and they have been requiring regular opioids, for example, then we don't necessarily want them to not have the opioids to cover their cancer pain when they can't take their tablets. So if the medication's in the house, then the nursing staff can help the family to use the medications to maintain symptom management at home. And again, complex cases, that's where the palliative medicine specialists and physicians come in and support advice and support the GPs in managing the medications. So there's been a relatively recent collaborative between the Northwest PHN and the East Melbourne PHN and also the Southeast PHN on Metro Melbourne pharmacy stocking end-of-life care core medicines. So, and we're talking injectable morphine, injectable midazolam. We talked about the buccal clonazepam drops, injectable metoclopramide, injectable haloperidol, injectable buscopan for secretions in this case. And that's because we've recognized a lot of time people don't have time to wait for the medication to come in the next day, and we try to make sure that as widely available as possible. So there will be links you can find from the resources that the PHM can provide, and you can literally Google this as well, and work out which pharmacies that that are part of this initiative. In Banksia specifically, we do have ENs, enrolled nurses, to focus on personal care provision and family learning around the techniques and the best way to provide hands-on care. And they do help out with respite partially as well, but of course it is not it's not able to be 24/7 in that case, and it's often trying to help filling the roster, so with the family, and also with things like care gateways, accessing further support. And they do, the registered nurses do attend home and can provide verification of death. And then we move on to the actual medical certification of cause of death. So a quick reminder, verification of death is the examination of signs of life, because there's no sign of death, there's an absence of signs of life. And but yes, the medical certification is the report or request to birth, deaths, and marriages for confirmation of someone who died. And this is for legal purposes, statistical and public health purposes, family members, and safeguard purposes more than anything. So yeah, just very quickly, people can be transferred to the funeral service after the verification, but they do need the medical certification before they can have the funeral or dispose of the body. So the doctor who's responsible for a person's medical care immediately before death, or whoever examines it after death, should notify within 48 hours. But this is not strictly policed. And again, in the community, that is our general practitioners. The cause of death is the disease or injuries which initiated the train of morbid events leading directly to death, or the circumstances of the accident or violence which produced the fatal injuries. Which means if they die from a complication from cancer, you can just put the cancer down. So you don't have to list everything that the person's, every complication that the person's had since then. So it is just the main initiation of the morbid events. So in some cases, we may ask the hospital doctors to help complete the certification of cause of death, and that may be that they're very, very, very recent discharge from hospital. In some cases, if we've met them, we may be able to help completing the certification. But in most cases, the GP is the primary treating practitioner and will be approached first. So yes, and we do provide up to 13 months of bereavement support, but also there is Australian Centre for Grief and Bereavement if the person were not on the community palliative care program. So finally, referring to community palliative care. So we mentioned that anyone can, and you can certainly just give us a call or visit our website. But if you're not in our catchment, or you're not sure which catchment you're in, just look up in Palliative Care Victoria. We have a service finder. Looks like an ad, and that's tricked me before because it's a very colorful button. But find that big button or find a service and click on it and search the postcode of where your patient lives in. And again, if in doubt, call someone. There is a statewide, nowadays, statewide palliative care advisory service that's run from Royal Melbourne. And there's a number there, and that will be part of our resource that we commonly advocate and publish out. And there are all the other hospital-based palliative care services, and really any of them will be able to point you to the right direction. And if they're not the best service to help you, they will know who is. And that's just some references which we will share with the slides.
Big thank you so much, Chen, for that information on Banksia, but just community palliative care in general. Great presentation. I'll now hand over to Hao for a more of a detailed look at advanced care planning.
Thanks, Jack, and thanks to the Northwestern Melbourne PHN for organising tonight. I'm going to talk about advanced care planning because it can make a big difference in how our patients' journeys are and how their care can change. And what we know is that not having adequate goals of care discussions, advanced care planning can be a barrier to palliative care in general. If you move to the next slide, Nat, I think what advanced care planning is, it's all about the communication, the conversations we have. It's about planning for how you want to be treated, how you want to be cared for, and I guess how you want to live. And it's about planning so that we know what is an acceptable outcome that is defined by you. And so I think part of this conversation is just reframing it to how can we best care for you. I think the impetus for advanced care planning comes from when residents see family members go through the same process, go through the process of not being able to make these decisions and having the guilt of putting a family member through that. And I think a part of that is understanding that you can plan for these difficult conversations and you can plan for these things that will happen in the majority of the people who we talk about in palliative care. As Terry's mentioned, there's a level E consultation for longer consults over 60 minutes that can be used for advanced care planning in palliative care and end of life. Part of the reasons for advanced care planning are similar to those that are why you would refer someone to palliative care. And so there is that cross between, there's the requests, frequent admissions to hospital, maybe conflict in decision making, but also for those who may have difficulty in communicating, but are able to do so with more support. And so whilst there's a large crossover of palliative care and advanced care planning, one doesn't necessarily need a palliative care service or be involved in order to have advanced care planning. And I think it's important to think about it as who you would want to speak for you and how would they know what you want. And so part of this is planning for these discussions. At the Northern, Barbara Hayes, who's been pioneering advanced care planning for many years now, has set up advanced care planning in 3 steps. And so it fits quite naturally with ACP. And it's something that's well adopted across the state, across the nation. And I think it's 3 easy steps that we can remember of how we can approach advanced care planning and approach the different steps. A is appointing another, and we'll go into detail about appointing somebody you trust to help make those decisions when you cannot. C is about communicating this, making sure your family, your medical practitioners, your GP, your friends, they know these are your goals and preferences. So it's not a surprise when that time comes. And P is putting it all on paper. So having your advanced care directives, but nowadays also having values directives, plans in palliative care plans in residential care, as well as goals of care documented as well. And so in more detail, I guess the role of a general practitioner in helping filling these forms is to certify that this person has the capacity, they understand what they are signing and who they are nominating. And so someone with capacity can appoint a medical treatment decision maker. And this is the person who will make decisions when the person loses capacity and isn't able to make it for themselves. Who should appoint a medical treatment decision maker? Everyone. But the ones who I think are very important is when there's that family conflict, when you don't trust a family member to be able to uphold your wishes, when you don't have a medical treatment decision maker, so you've got no family relation, and the person you trust is that person, your neighbor, that person who's been caring for you potentially, or a good friend. And then especially when there's cases when there might be confusion about who the correct medical treatment decision maker is. And so I think getting these in place is really important. And it's quite a simple form to fill. The patient would nominate who it is, and with you, you would sign that they understand. And then the person that they nominate doesn't have to be with you at the time. That can be done afterwards. And they would get their signatures witnessed accepting this nomination as a medical treatment decision maker. And so your role would be to certify that capacity, and there would need to be a witness at the time of doing this as well. So use that communication, chatting to your medical treatment decision maker, friends, family, and also faith leaders. We know in our diverse population here that religion plays an important role in the way we want to be cared for, but also the way we want to die. And so I think part of this is discussing with the people around, the people you trust, so again, that it's not a surprise when these conversations come and these documents come up. P is putting it on paper. And so the Advanced Care Directive from the Victorian government has two sections. One is an instructional directive, and that is your concrete consent, refusal, instructions to healthcare workers. And someone with capacity is able to state the things that they want and then the things that they don't want. And so we know that Jehovah's Witnesses are excellent advanced care planning advocates. They write the most amazing advanced care directives in stating what they do and don't want. A values directive are the things that bring meaning, bring value to the patient. This is the way I'd like to be cared for. This is what I would want in the event that I was dying. These are the things that are important. And I think you can see how this is about a conversation about knowing the patient in front of you and learning about the things that are important and being able to use that information to care for them. And so the role of the GP and a medical practitioner is again to certify that they have capacity and they understand the statements they're making. There's probably a bit more nuance to an instructional directive as compared to nominating a medical treatment decision maker, putting a values directive. And so you might talk about in which situations and being very specific. In the event your heart was to stop, would you accept CPR or not? And then specify in what situations. For those with dementia, having things like no artificial feeding, not having IV fluids, they might be important things to say, I would not want those things to happen. And so you would put that in that instructional directive. I think it's important for those who have really strong views, but also for those who don't have a medical treatment decision maker, because this is what will be used to help look after them. This is what a doctor, someone in the hospital will look at. It's also important in that situation when there is family conflict, when there's differing views, when some children want one thing and the others want something else. This is their voice when they don't have that voice. So we talked about the whole process, and it's learning about what is important to the patient, their story of their illness, and learning about what matters most, what they're fearing and what they're hoping for. But at the same time, we know that it's an emotional period for families as a whole, and we need to respond to the emotions that we see rather than try to work it out cognitively. I think it's important to acknowledge the loss of independence, but also praise the love and care that these patients' families have. I like to use the phrases "I wonder," "I worry," and "I wish" because they bring about a safe way to bring about curiosity about learning, but also highlighting the importance of where we are now. I wonder if your heart did not get better, what are the things that are important? I worry that you may not be able to leave your home anymore because of how your heart is. And I wish that we could make this all better, though at the moment we can see things aren't improving. And so they're very powerful ways we communicate with our patients. I think there are two groups here that are the experts, and you as their GPs, the clinicians, you know what medical treatment and you have that expertise. Whilst on the other hand, there's families and the patients who know what's important to them. Part of this is shared decision making, and together you're making a plan for what you think is best in line with the goals and preferences. And I think an important part of shared decision making is giving that recommendation. Families look to us to be able to provide what we think, interpreting the things that you've told me that's important, that we know about them, and being able to provide that recommendation. So I think that's a critical role. I've touched on goals of patient care, different to our advanced care planning forms, and I think a bit more applicable in hospital, but also in residential care especially. And I hope one day it'd be something that we bring into the community as well. We know how complex things are, and goals of patient care, I think of them as a care now plan. It's a plan to be able to decide what treatments we are going to offer at that moment when there's an emergency. So the things that are important are CPR, intubation, ICU, and going to hospital if they're in residential care. And so, as you can see, it's understanding the patient's medical illness trajectory in addition to their preferences and values, and that is that shared decision-making process. For someone with capacity, it's a decision about what is clinically feasible and what is being offered with the patient, and then deciding an overall plan. With someone who doesn't have capacity, it's using their instructional directive with their medical treatment decision maker, their values directive, and using that to make their plan. Great resources are the Office of the Public Advocate and decision-making process. And this flowchart is really great. I look at it all the time. It has the medical treatment decision-making hierarchy, and it just talks about the consent process, especially for those who you have concerns about someone's capacity. I think traditionally we've talked, it's easy to think about palliative care as that last stage and that clear association with death and dying. But what we know is early palliative care improves quality of life, but we also know in cancer, it's shown that it improves survival as well. And so there's that integration of palliative care that can coexist with treatment-focused care as well. And so the reason I bring that is it's when I saw this slide recently, talking about the waiting room revolution, it's a Canadian podcast by an oncologist and a palliative care physician. You think of palliative care, the word palliative can be used in so many phrases and has so many connotations. It's a noun, a verb, a place, a time, a point in time. It's a person, it's a team, and you can see how it's so hard to get everyone on the same page when everyone thinks about it so different. It's used so differently. But to me, palliative care is a philosophy and approach. It's a way of thinking about things and valuing the things that are important and using that as your basis. There are a lot of myths about palliative care, and I've listed only a few that are a part of this spectrum that we talk about. There's fears of hastening death, that it's giving up hope, that it's a loss of independence, and that association with dying. And we could talk about for days and have arguments about what it is and what it isn't. But what we know is that early palliative care is important. It's a communication. And so, Nat, if you're moving to the next slide, it's that communication, I guess, that I really wanted to focus on. And so again, the waiting revolution talks about how we can enable our patients who have a life-changing diagnosis, how they can communicate with their health professionals. But I think us as health professionals, the carers for these patients, we have an important role in how we invite discussion, how we bring about curiosity, but also bring about a sense of reality and understanding. I think the language you use can be very important, and I really like this phrase. I think asking patients, this illness has a normal storyline and pattern. Do you want to know what to expect in the future? We've got two roads moving forward, and we're going to hope for the best, but we're also going to plan for the rest. And I think these are things that we all do naturally, but I think it's important that we be able to enable our patients to feel safe to talk about these things, and that language is really important in how we approach both advanced care planning as well as palliative care. And so I think the biggest key takeaways is that advanced care planning and palliative care is everyone's business. It's something that we incorporate into our everyday practice, and having that communication and planning is important. As Terry said, some people need multiple conversations. And what we know is that planting that seed, having that initial discussion makes every subsequent future discussion a lot easier. And so I wish that it'd be as easy as a tick box and something that we could implement with everyone. But we know that advanced care planning, palliative care, they're difficult conversations, they're difficult topics, and some people may not be ready. And it's just finding that time and space when they are and being able to support them at that time. Thank you.
Thank you so much, Hal, for that wonderful presentation. I think that certainly the power of language is something I've come to understand and really respect with palliative care. And certainly I've come across the waiting room revolution quite recently, and it's a fantastic resource as well for those interested. I'm now going to hand over to Catherine from the Mercy Community Palliative Care team to have a closer look at the distinction between palliative care and voluntary assisted dying.
Thanks, Jack, and thanks everyone for coming. My name is Catherine. I'm one of the palliative care consultants working with Mercy Palliative Care. So we're based predominantly in the western suburbs of Melbourne. And so I'm just going to give a bit of a talk about voluntary Mercy Palliative Care Service and voluntary assisted dying, and kind of the interaction between the two. The focus is on our service, but I believe what I say kind of is applicable across kind of Banksia and Melbourne City Mission as well. So just to start with, The topic of voluntary assisted dying does raise difficult and kind of complex ethical issues, and there's quite a broad spectrum of opinion on and support or opposition to voluntary assisted dying, or VAD, within the Australian community. And this diversity of opinion is also reflected within the palliative care community. So as we go forward, I just would like everyone to kind of approach this topic with care for themselves and care for the other people participating in this discussion. So just a quick definition, that voluntary assisted dying is administering a medication for the purpose of causing death in accordance with the process set out by law. It's for those who face an inevitable imminent death as a result of an incurable disease or illness or medical condition. It commenced in Victoria on the 19th of June 2019, and all the other states of Australia have now followed suit. So it is legal in all other states of Australia. The Australian Capital Territory has passed laws that don't come into effect until I think November 2025, and in the Northern Territory it remains illegal. So the Victorian voluntary assisted dying legislation provides this legal framework for people who are suffering and dying to choose the manner and timing of their death. The medication is usually self-administered or physician-assisted. Voluntary assisted dying is available if a person is physically unable to take the medication themselves, or if there's a concern about their ability to digest the medication. So to be eligible, this must be a voluntary process, and it must be initiated by the person themselves. So healthcare professionals are prohibited in Victoria from bringing up the topic with patients initially, and it can't also be initiated by family members or friends who do, sometimes inquire about it on behalf of a patient. It has to be initiated by the patient themselves. So in Victoria, it's only available to Victorians who are experiencing suffering that cannot be relieved in a manner that that person themselves considers tolerable. The prognosis needs to be less than 6 months or less than 12 months if it's a neurodegenerative disease. They must be over the age of 18. They must have lived in Victoria for at least 12 months and be an Australian citizen or permanent resident, and they must have decision-making capacity. This is just a snapshot of the VAD data for Victoria from July 2023 to June 2024. And so just a couple of things this is readily available on the internet. I just wanted to highlight the number of applications started is 768, so that's for the whole of Victoria. So that's, I don't think, a huge number. I know Chen put up the number of referrals to Banksia before, and it was over 1,200. For Mercy, our referrals for the same time period was over 2,200. So, certainly is nowhere near the kind of numbers of referrals we get into palliative care. But the other thing I wanted to look at was this, just in the bottom right-hand corner, the palliative care engagement wheel. So about 25%, we either don't or we don't know whether or not they have palliative care engagement. And I think, personally, from my point of view, I would like for the kind of all patients who are kind of accessing VAD to have some palliative care engagement somewhere along the way. It's ultimately up to them, but I'd like to see that number higher. So I just want to talk a little bit about the kind of interplay with voluntary assisted dying and palliative care, and kind of primarily answer these two questions. If a patient wants to access voluntary assisted dying, can they also have palliative care? And then conversely, if a patient is already receiving palliative care, can they also access voluntary assisted dying? I'll go on to this position statement from Palliative Care Australia in regards to voluntary assisted dying. And their stance is that the practice of providing voluntary assisted dying is separate from the practice of providing palliative care. They believe the choice to explore voluntary assisted dying shouldn't be based on a lack of access to palliative care, and every Australian should have access to quality needs-based palliative care. And then the other point, that withdrawing or refusing life-sustaining treatment or providing strong medication to relieve suffering does not constitute voluntary assisted dying. And this would certainly be part of our kind of standard palliative care practice, to be, you know, assisting people who are withdrawing or refusing life-sustaining treatment, and also providing medication to relieve suffering. So in terms of voluntary assisted dying and Mercy Health, Mercy Health as a faith-based organisation does not support voluntary assisted dying and will not provide or facilitate voluntary assisted dying in accordance to the Catholic ethical standards. And as I mentioned before, we are legally bound not to raise this subject with any patient. However, we're not taking a kind of head in the sand approach or fingers in the ears, we're not listening approach. All of our palliative care staff at Mercy are trained in how to respond to patients who bring up the subject of voluntary assisted dying. So if we're asked by a patient about voluntary assisted dying, we will respond in a compassionate manner, congruent with our identity values and our tradition of person-centered care. So everyone does go through training in how to respond to someone who brings up this option. So we won't be kind of shutting people out or making them feel unheard if they bring up that topic with us. And just to kind of reiterate that, we will not abandon or impede a client participating in voluntary assisted dying, nor will we encourage them either. We will continue to provide our palliative care alongside them accessing the voluntary assisted dying process separate from our service. So yeah, hopefully that that was the main thing I wanted to bring up about that you know, we will continue to look after patients who are accessing VAD all the way up until the point that they take the medication, and we also provide kind of care after death for people who have taken the VAD substance, including death verification by nursing staff. Our nursing staff, though, won't be present during the actual administration of the voluntary assisted dying substance. That's probably the only moment that we would be actively kind of stepping back from the patient and family, just in that moment. But otherwise, our care continues as standard. So, any questions?
Thank you for that, Catherine. Yeah, and just with the questions, guys, we're now opening this up to everyone. So if you have a question for Chen, Catherine, Hao, or Terry, feel free to raise your hand, put it in the chat. I'll keep an eye on that for our presenters. But yeah, any questions from the group? Nothing coming through yet. So we've got our first one coming through just on the chat, guys. What percentage of PAL care patients opt for VAD? So this one's probably for Chen, Hao, and Catherine. I don't know if you'd have figures on this, guys, or do you have a comment for Santosh?
I don't think, off the top of my head, I don't know. I do think we keep the statistics within Mercy. I think we have we do have the knowledge there about how many of the patients on our books are kind of pursuing voluntary assisted dying, but I don't know off the top of my head. But it's not, certainly isn't a large proportion of our patients.
I'll just add to that and echo Catherine that but because it is a separate service in a sense, so we're not privy to every single person accessing VAD on the program, nor does it create any barriers either way. So again, we're not here to stop people accessing VAD. Nor people accessing EAD will stop us engaging. In fact, often people will need more care, as with any palliative care situations. But if they have existential distress, they need all the support they can have as well. So in terms of the numbers that we know of, I think people who actually do die with lethal substances is not common. So there's a lot of people who explore the process or in fact go through with the eligibility assessment and have the medication supplied, but not many actually eventually use the substance, and probably about 10 definitely or less than 20 a year in the past few years since it's legislated in our catchment.
Perfect. We do have another chat question coming through the chat, guys, just in relation to VAD from Adriana. So from the initial discussion raised by the patient for VAD, how long does it generally take for it to be organised and carried out? Do you guys have, I guess, a rough time frame that you know of?
The experience has been roughly 4 to 6 weeks. I think in total, if we add if there's no waiting time for all the appointments and coordinating the medication supply, then I think the quickest it can be would be about 2 weeks. But that's very rare, and even when we try to rush it, and on average, 4 to 6 weeks would be a ballpark figure.
Perfect. Thanks, Chen. Any other questions at all for our panel, guys? Feel free to pop them in the chat or just raise your hand if that's easier.
I'll just ask a simple question. What if your clinic doesn't have a doctor who does VAD? How do they find a doctor?
Perfect. Thanks, Terry. Guys, do we have an answer for Terry?
So, sorry to jump in, and others feel free to answer as well. So VAD, you don't technically need a referral. You can access the statewide coordinators to help you find a provider, and the patients themselves can find the coordinators and call the numbers or email them to get the support in finding a provider. I think the key is it does need to come from the person. There's a lot of information for the families that they can already read from the websites, but ultimately, to start the process formally, the person needs to talk to the coordinators themselves and eventually talk to the providers themselves.
And they provide a visiting doctor to go and see them?
Again, it depends on, to a degree, it depends on where the patient is. So yes, there are VAD providers who does do home visits, but that's not universal, and of course there are limits to how far the provider can travel as well. Currently it's not legal to progress the process on telehealth or telephone. So appointments do need to happen, and yeah.
Thanks very much.
All righty. I think we might be just starting to slow down a bit, guys. I note that we have hit 8 o'clock and it's been a long day for a lot of us. So I do just have a bit of housekeeping to finish off, guys. And with any webinar, there's a few sort of plugs that we have to go through. Certainly, if any questions do pop up, I'm happy to go through them once I've gone through my final slides here. So I just want to let everyone know that Northwest Melbourne will be running a QI Spotlight in the new year. So the Spotlight's going to run between February and April, and it's going to focus on building general practice capability in managing palliative care patients. So the first part of the Spotlight will be attending tonight's webinar. But essentially the idea will be you'll attend the first workshop, you will come up with a QI activity around either palliative care or advanced care planning that we'll support you with. You'll have a chance to implement that as a practice, and then we'll have a workshop to review how that all went. So we're really excited to be offering this, and there will be CPD points attached to this as well in lots of different areas, and we'll be putting up more information about this event shortly, so look out for our website. But in the meantime, if this is something your practice is interested in, yeah, please get in contact with me at that email address. Next slide, Nat. So next is another program that we're currently running, and we have been doing so for the last few years. It is our palliative care practice visits for general practice. So we run this with Eastern Melbourne PHN and the Northwest Metropolitan Region Palliative Care Consortium. So basically offers general practices the opportunity to connect with local community palliative care services. So general practices can request a visit from community palliative care teams, and a member will come out and provide them with information, education and support, and help improve that understanding and access to community palliative care services. So this is available free of charge to anyone in the Northwest Melbourne catchment, but also those practices in Banyule, Nillumbik, Whittlesea. So really great opportunity. I've been out to a few practice visits recently, and it's a great way for the practice team to meet their local community palliative care provider. And you can apply on our website, and I will also put the link for that in the chat if anyone would like to apply. Next up, we do have health pathways. So I think most people on the webinar would be aware of health pathways. It is a terrific resource run by Eastern Melbourne PHN and Northwestern Melbourne PHN, and is supported by local GPs, hospitals, health networks, community health providers and other health professionals. It is a single website that provides clinicians access to comprehensive collection of locally relevant clinical information and guidelines, and is designed to support general practitioners, other healthcare providers delivering consistent and evidence-based care to patients. It also includes medication information, referral information, and further resources which can be used at the point of care. And we have a lot of terrific palliative care pages. So next slide, Nat. Next one, we do have a short video, but I think it'll be easy just to show everyone the pages that we do have. Just next slide, I think. Nat, there we go. So Health Pathways has a number of fantastic pages. So you can start to see the ones that we have there. So palliative care medications, referrals, legal and ethical pages. Next slide, Nat. We also have emergencies in palliative care, essential conversations, and symptom control in palliative care. So great. Yeah, really terrific pages, all updated very regularly, all with terrific information on them. Also, you may not be aware that Health Pathways is a tool that can help you with reflective learning. It contributes to CPD hours. So this is for both the Australian College of Rural and Remote Medicine and the Royal Australian College of General Practitioners. You need to complete 30 minutes of each of a performance review and educational activity. After completing these, you can enter the details in the reflective activity template and submit them online with the links or via my CPD app. So if you reside in the Eastern Melbourne catchment or Northwestern Melbourne catchment, you can sign up to Health Pathways. You'll get free access for 10 days. Then the Health Pathways Melbourne team will review your eligibility and you'll be given access after that if you are eligible. And the next slide is just where you can sign up to Health Pathways Melbourne. So you can follow the QR code there or jump on the website. And finally,